Hello everyone, I am Dr. Parag, Director and Consultant Hand Surgeon at Pinnacle Orthocentre in Thane. Today I would like to explain or discuss a very unique, rare but real case of a palmar dislocation of the distal radio-ulnar joint in a young gymnastic player. So she is 27-year-old female and she presented to us 3 months post fall while doing gymnastic activity, and her chief complaints were pain on attempt of movement and grossly restricted pronation, and that was affecting her daily activities. So these were the movements of the wrist. Left side was normal, right side pronation was grossly restricted. So this was the supination as shown in the picture below, and this was the pronation possible. It was hardly reaching to mid neutral and it was just not possible to have pronation, and she was suffering with this for 3 months. This was the flexion and extension in the wrist, and these were the x-rays. The x-rays showed that there is a volar dislocation or a palmar dislocation of distal radio-ulnar joint, and if you see the proper PA view, in that the distal ulna is hiding behind the radius, behind the sigmoid notch of the radius, and if you see the oblique view, the ulnar head is dislocated on the palmar aspect. Then we did MRI, and MRI confirmed not only dislocation but there was a soft tissue impingement into the distal radio-ulnar joint on the volar aspect, and the TFCC was completely torn. So there was a dorsal TFCC tear and full thickness tear of the distal dorsal radio-ulnar ligament. So if you understand the anatomy as shown in the orange dot, the dorsal radio-ulnar ligament causes rupture when the patient has a fall on outstretched hand, and that removes the support of the ligament on the dorsal aspect of ulna, causes palmar dislocation. It is one of the rare entity, but it is possible. So here the issue was, first of all, the palmar dislocation, which is rare, and then chronicity of the problem. It was a 3 months old problem, and there was a gross restriction of pronation in a right hand dominant gymnast, a professional gymnast player. If we don't treat this properly, then the risk of distal radio-ulnar joint and ulnar nerve compression in the Guyon's canal, causing the ulnar neuropathy symptoms, you cannot avoid. There was a treatment dilemma also, as it was a palmar dislocation. We had to approach from the palmar side, but the TFCC ligament was torn from the dorsal side, so we had to address that also. Then once you reduce, how to maintain the reduction, whether to put a wire, whether to immobilize, and how the post-op protocol should be followed, because in the literature palmar dislocation cases are extremely rare and they are reported very rarely. So we decided to choose volar approach. We explored the distal radio-ulnar joint, and when we explored, the ulna head was jutting out of the capsule on the palmar aspect of the distal radio-ulnar joint. Then we explored it completely and we did arthrolysis of the distal radio-ulnar joint. As the injury was 3 months old, there was a fibrosis, and that we had to remove and clear the joint space, and that helped to achieve reduction. So this was the arthrolysis of the distal radio-ulnar joint. Then we attempted to considered to repair a TFCC ligament, and for that we had to identify what are the proximal and distal margins of the triangular fibrocartilage ligament complex. So we first used the K-wire and marked our ulnocarpal joint. That is one point. So we understood that the proximal margin is at the ulnocarpal joint, and then we marked the distal joint like a capitohamate joint, and therefore that is how the middle segment we marked as a TFCC ligament, and then we repaired the TFCC ligament using suture anchor and stabilized the DRUJ. That is how the anchor was placed into the fovea of the distal ulna, and the TFCC ligament was repaired. Once we repaired the TFCC ligament, after that the distal ulna was reduced and the position was maintained in a mid-neutral position, and then we repaired the volar capsule, and the torn distal part of the pronator quadratus was also repaired. And this was the pre-op. On the left side we are seeing a pre-op x-ray, and on the right side the well reduced distal radio-ulnar joint with no dislocation. Post-operatively, we gave above elbow slab for 3 weeks. Then we converted that into a cock-up splint for another 3 weeks, and we started wrist flexion and extension exercises. Active pronosupination exercises were started at 6 weeks, and then all passive movements we started only after 2 months of surgery. We also suggested the patient to consider a scar mobilization 3 weeks post surgery in the form of desensitization technique as well as moisturizing cream application. So this was the follow up at 10 weeks, and the distal radio-ulnar joint was well reduced, suture anchor was well placed, and this was the restricted flexion and extension at 10 weeks. But at 6 months follow up, the patient regained full pronation as well as full supination and full wrist flexion and extension. And this was the movement, that was the pronation possible. Supination she already had, and this was the pronation possible. Thank you so much for watching this video. The message here is, if you happen to see any patient with grossly restricted wrist movement, even if you feel the x-ray does not show any fracture, these patients definitely require an expert opinion from a hand surgeon to find out any missed injuries like palmar dislocation of the distal radio-ulnar joint. Thank you for watching this video.